Our last speaker is Giulio Mastria with Body Ownership Alterations Emerge from Proprioceptive Impairment and Frontoparietal Network Damage.
So good morning. It's a pleasure to present my work on body ownership alterations in stroke at OHBM. So the most known body ownership disorder in stroke patients is somatoparaphrenia, a disorder in which patient, after an acquired brain injury, deny the ownership of the affected limb and also develop delusional beliefs about it, which is a prevalence of 7.5% in patients with right brain stroke. But actually, patients, up to 2/3 of the patients with an acute brain injury at 1 week at hemispatial neglect misidentify their own limb. And there is another condition which has been described recently by an Italian group, which is called Embodiment Plus, in which patients misidentify their own limb regardless of the visual features in particular conditions, namely when another individual's limb is placed in between the real affected hand and the trunk. In this case, the presence of this alien limb induces a bias in the reaching movement towards the alien hand, which shows already a strong relationship between the body ownership and motor control. So why is that? This happens because the representation of the body and of the upper limb in particular is not monolithic, but is based on different kinds of informations which are continuously combined online by the brain. So tactile information, proprioceptive information, information about the visual features of the hand and of its visuospatial coordinates. And while we have a tactile receptor and muscle spindles that relay information to the brain only about our hand, visual information is more tricky. The brain has to actively infer which visual object is a hand, which hand is our own. And this is something that patient with the brain lesion might not be capable of doing. So how the brain does this in healthy subjects? So the brain considers the congruency between multisensory stimuli, spatiotemporal coincidence that indicates the two stimuli come from the same source, and this is the patient's hand, the subject's hand. This leads to their integration and ultimately to the sense of body ownership. The ownership of the effector clearly, the self-attribution of the effector clearly affects the motor planning and execution. So our working hypothesis for this study is that stroke patients may experience body ownership alterations because of a combination of unisensory deficits, which can impair the detection of congruency between sensory stimuli, and higher level integration deficits, namely alterations in the way in which sensory cues are put together independently of their precision. We studied 20 stroke patients through a virtual reality paradigm to assess body ownership in their intact and affected limb, proprioceptive and visual spatial deficits. They also underwent clinical assessment, and we collected lesion data, and also 35 age-matched healthy controls. So to study the inferential process of the brain, we have to challenge it, and we need a suitable task. This is the main task of our study. It's a visual proprioceptive disparity task inspired by the visual motor rotation paradigm, and a study from Fang 2019 on the macaque brain. So in this task, subjects are asked to reach targets with a real unseen hand using their proprioceptive information, while a virtual hand providing visual information is displayed with various degrees of disparity in order to prevent adaptation. Subjects also rate the ownership experience on a trial-by-trial basis for the virtual hand. So what the brain is doing during this task according to our model. The brain is evaluating the probability that the two stimuli originate from the same cause, namely participant's hand, and therefore the stimuli need to be integrated, or the two stimuli originate from two different sources. In this case, the final reaching position will rely mainly on the native proprioceptive information. What happens in healthy subjects? That you see here plotted the level of bias induced by the presence of the virtual hand according to as a function of disparity, which can be a negative or positive angle. At low levels of disparity, the visual bias induced by the virtual hand increases almost linearly with the disparity, because vision and proprioception are strongly integrated, and also subjective ownership are high. At higher levels of disparity, instead, the influence of the visual hand on motor behavior decreases, because vision and proprioception are less integrated, and subjective ownership ratings here on the right are low. The free parameter of the Bayesian causal inference model can be fit on the behavioral data, on reaching error, and the formula is complex, but you can see that the final estimate of the and reached position highlighted here in green in the formula depends on two critical parameters, so the proprioceptive and visual precision highlighted in blue and red here. This formula can be inverted to obtain the probability of visual proprioceptive integration, here in dark green on the right, which you can see follow the profile of ownership ratings in light green. From these two curves, we can extract two different windows of ownership, a behavioral ownership window and a subjective ownership window, and find the relationship. So how patients behave at this task? You can see already qualitatively that they are more biased and experience higher ownership for a higher level of disparity with the affected compared to the intact hand, and this is also true when comparing with healthy subjects. But what is the link between these two components? So we found a strong correlation between the ownership rating and motor behavior, even when regressing out the average effect of disparity. You see here on the left that the red dots concentrate close to the red line, which is which marks the complete visual dominance, and blue dots, low ownership, are concentrated in trials in which where the subject followed the proprioception marked by the blue line, the blue horizontal line. And this shows that in this context, using this paradigm, we can actually capture covariation in body ownership and motor behavior that are based on stochastic fluctuation of multisensory integration, as it would be the case in a probabilistic framework of causal inference. So what we have done so far, we have found a suitable task to challenge the brain inferential process. We have validated a computational model that can describe this process. We have demonstrated that there are subclinical body ownership alterations in stroke patients, and that these are related quantitatively to motor behavior. We need to demonstrate that they are related to unisensory and higher level multisensory deficits. So, correlating the amplitude of the ownership windows, we found that both correlate with the proprioceptive precision, and this means that proprioceptive deficit at least partially account for body ownership alterations in stroke patients, and that the multisensory integration process still approximates optimal Bayesian inference after stroke, as predicted by the model. What's the role of high-level integration deficits? So the Bayesian model described the statistically optimal way of combining stimulus given uncertainty in sensory information. In this context, high-level integration deficits can be defined as a wider ownership window, not justified by a loss of sensory precision. However, deviations from optimal inference cannot be taken into account directly by a Bayesian causal inference model, but we can find their neural source through lesion analysis. We need to isolate them by regressing out proprioceptive deficit and control for non-lateralized or general cognitive impairment which might be present in stroke patients. And we do this by taking the difference in the ownership window between the affected and the intact limb. Doing this, we found a strong correlation with the damage of the frontoparietal network, in particular fibers connecting the supramarginal gyrus with supplementary motor area and dorsolateral prefrontal cortex. In our view, the fibers connecting posterior region performing sensory fusion estimate and dorsolateral prefrontal cortex region performing the causal inference, which patients cannot efficiently do. So, in summary, body ownership is altered in stroke patients with sensory deficit, and the relationship between this alteration and motor behavior can be quantitatively predicted through a Bayesian causal inference model. Low-level proprioceptive deficits partially account for body ownership alterations, but lesion of the frontoparietal network contribute to impairment of high-level multisensory integration functions and pathological embodiment. This theoretical framework and experimental framework puts these conditions from mild subclinical deficits to more clinically overt body ownership deficits on an ideal continuum which can be thus interpreted. If you want to know more, this paper has been accepted for publication recently, and I have to thank for this my colleague Tommaso Bertoni and my professor Andrea Serino of the University of Lausanne. I also have a poster 2083 if you have a question. Thank you for your attention.
Thank you. My co-chair is limiting me to just one question. Have you accounted for the role of spatial representation, deficits or abilities in the patients? Because it seems that your task involves a level of space representation, right?
So we measure visuospatial deficits, and there are through a localization task, and the subject, and this does not correlate with our measures. Also, we measure separately. We conducted separate analysis for patients with right and left brain stroke, which can also show deficits in spatial representation, especially on the right, and regressed out cognitive scores, and also integrate in our as a covariance the opinion of the therapists that normally have follow the patients day by day, and these do not correlate with ownership measures. Unfortunately, because I think it's a very important component, and we should take account of this.
Thank you so much. Thank you all for attending the session, and see you for the closing ceremony.